Hello everyone and welcome to the latest MDPI webinar on clinical medicine, which is entitled Dry Eye 360, looking at dry eye disease from all directions. Thank you very much for joining us today. This is the third webinar of a series that is based in special issues and sections from our Journal of Clinical Medicine. Our chair today is Dr. Anat Galor from the Miami Veterans Affairs Medical Center and the Bascom Palmer Eye Institute from the University of Miami Miller School of Medicine in the States. With our chair, we will have three speakers. The first one would be Jennifer Craig, Dr. Jennifer Craig from University of Auckland in New Zealand. Then Dr. Anat Galor from Miami Veterans Affairs Medical Center and the Bascom Palmer Eye Institute, as I said before. And finally, Professor Pflugfelder from Baylor College of Medicine in the States. We will have time for questions, so please submit them at any time during the webinar in the Q&A box. And as we have more than one speaker today, please mention the name of the speaker together with your question. I would also like to remind everyone that this webinar is being recorded and that the recording will be available soon at the webinar's webpage. Now I'd like to introduce our chair. Dr. Anat Galor is a cornea and uveitis trained specialist with a dual appointment at the Miami Veterans Affairs Medical Center and the Bascom Palmer Eye Institute at the University of Miami Miller School of Medicine. She completed an ophthalmology residency at the Cole Cleveland Clinic and uveitis fellowship at the Wilmer Eye Institute, Johns Hopkins University, and also a cornea and external diseases fellowship at Bascom Palmer Eye Institute. Dr. Galor currently runs the Ocular Surface program at the Miami Veterans Affairs and has focused her research on understanding mechanisms of pain in dry eye, with an emphasis on studying new diagnostic and treatment modalities. Over the years, she has participated in several dry eye-related committees, including the Tear Film and Ocular Surface Society, and served as president of the Ocular Microbiology and Immunology Group. She also sits on several educational committees within the Academy of Ophthalmology. Now I hand over the floor to Dr. Galor and enjoy the webinar.
Thank you so much for having us all here. We're very excited that dry eye has made it to clinical medicine. We do think it's a really important topic that all clinicians and researchers should care about because it really encompasses so many facets, and that's what we're hoping to discuss here. And so just to kind of start off, and hopefully you'll see this as a theme in our presentations, dry eye is not one thing. It's a compilation of symptoms and signs, and different types of dry eye occur because of different things that happen either internally, locally, or as part of the external environment. And so I'm so excited to have a panel of amazing dry eye clinicians and researchers who are going to help me introduce this topic. And we're going to shake up the order a little bit because we are very fortunate to have Jennifer Craig, who is coming to us all the way from New Zealand. And she is a really amazing optometrist who has really been part of the dry eye field for many, many years. She both sees patients and performs clinical research and has been on many committees that have increased education about the topic, most recently the Tear Film and Ocular Surface Society, where she served on the executive committee of the DUES-2. And she has focused a lot of her research on understanding the connection between dry eye and the local environment, meibomian glands, eyelids, and that's what she will be sharing with us today. So thank you so much for being here with us and helping us make this really an international panel. Thank you.
Thank you very much, Anat. It's a pleasure to be here. I'll just share my screen. Okay, so it's my pleasure to be here, and thank you so much to Anat for inviting me to be part of this. It's such an honor to be with such esteemed speakers. So I'm going to talk a little bit about the local neighborhood and dry eye disease and how these impact each other. Oh, I will try to move my screen forward. So these are my disclosures, but none of them impact what I'm going to say today. So TFOS used to revise the definition of dry eye, and I'm sure this is familiar to many people now, describing dry eye as a condition that has signs and symptoms in which tear film instability and hyperosmolarity ocular surface inflammation and damage, as well as neurosensory abnormalities, play etiological roles. It's recognized as a disease, and it's recognized as multifactorial. So multifactorial means that there's very many reasons why we might have a dry eye. And it's nicely depicted here in Baldwin's diagram to show the many different conditions and diseases that may cause entry into what we describe as a vicious circle of dry eye disease. And basically what that's describing is this lacrimal functional unit being in imbalance. And when any of those layers of the tear film or any of the glands supplying the tear film are affected, the tear film goes into imbalance. And that sets off this cascade here and this vicious circle of dry eye disease. And part of that, up here, you see the part that's related to meibomian gland dysfunction or the eyelids or lid disease in general. And that's what I'm going to be talking about. So as I said, these main components would be tear film instability and hyperosmolarity, as we saw from the definition, ocular surface damage and inflammation. And what we need to do as clinicians is to work on trying to reduce and trying to break that vicious circle in some way in order to restore homeostasis to the tear film. So lid disease is one of those key aspects that feeds into that vicious circle. And what I would like to talk about today is the scale of the problem, pun intended. What is blepharitis? What impact does it have? How common is it and who's affected? And most importantly for us, how do we manage that in clinical practice? So what is blepharitis? Well, in the broadest sense, it's inflammation of the eyelid, according to the term. And that can be subdivided into anterior or posterior, although quite often we see features of both of those. So when I talk about anterior or posterior, we're talking about the lamellae of the eyelid. So the anterior part being the skin and the lashes, separated from the posterior lamella by Marx's line or the mucocutaneous junction. And the posterior lamella is the one that contains the meibomian glands. So anterior blepharitis we think of as really being the crusting on the eyelashes. That's what we see clinically. And that can be seborrheic, where it's kind of like dandruff, and you get either dry or oily deposits on the eyelashes. And this is often accompanied by concomitant scalp dandruff. So patients who have dandruff in their heads, in their hair, may also see this around their eyelashes. Or staphylococcal, and that's harder deposits. They're more difficult to remove physically, and they grow with or move with the lash. As the lash grows, you see these deposits moving their way down the eyelashes. And for those that are affected by this, sometimes they can actually be affected by both seborrheic and staphylococcal as a mixed blepharitis. In the more severe cases, the features observed may extend beyond the crusting, so that you start seeing whitening of the lashes, loss of lashes, misdirection of the lashes. It may be associated with acute infections or with chalasia. You may see marginal keratitis, which is not infectious in itself, but it represents a hypersensitivity to the bacterial exotoxins. These occur most commonly at the point where the lid crosses the limbus. So we often see them around 2, 4, 8 or 10 o'clock positions, and are usually visible as infiltrate, separated from the limbus by a lucid zone. The other type of anterior blepharitis that we see quite commonly is Demodex blepharitis. And that's where we see cylindrical dandruff or collarettes around the lashes. So a little bit different from the ones I spoke about just a second ago. These ones now form a sheath around the eyelash, just at the just where the eyelash emerges, and quite often actually be kind of bound to the tissue. And this is seen clinically as, or that was reported by the patients as lid margin hyperemia, redness of the lid margins. So not necessarily the whole lid, but just right at the lid margin. and irritation or itching right at the lid margin again, and can be associated with fragile lashes or loss of lashes. So these are, and you can see a little picture of them here. This is what they look like if you epilate the lash and look under and put it under a microscope. This is what you can actually show your patients those and show them moving, which helps with compliance with cleaning your lashes sometimes. Sorry. So that's anterior blepharitis. Posterior blepharitis is now the posterior lamella of the eyelid, and there's more than one cause, but the most common form that we see is meibomian gland dysfunction, and it's a major contributor to evaporative dry eye disease, the main type of dry eye disease that we see. Clinical features include lid margin thickening. We may see excess keratinization on the surface of the lid margin. That shouldn't be keratinized, that should be mucous membrane. But if in meibomian gland dysfunction, we often see the keratinization extending from the skin side to cross over the lid margin, and that can alter the position of the mucocutaneous junction or Marx's line, and it can start to become a little wobbly when you look at it on the slit lamp. There's lid margin redness, telangiectasia, and notching where there's scarring where the meibomian glands drop out in advanced cases. It's often associated with anterior blepharitis, so you'll most often see both of them together, and it's considered prevalent, chronic, and progressive. So there was quite a lot written about meibomian gland dysfunction in 2011 when the International Workshop in Meibomian Gland Dysfunction was published, sponsored by TFOS. And they described meibomian gland dysfunction, all different aspects of it, including its pathophysiology. And the main features were considered to be the gland blockage that occurs, secondary to hyperkeratinization, which can occur within the acini of the glands, ductal stenosis, so a closing off of that duct where the meibum would normally flow out in the meibocytes, and stagnation of the oils as you get that gland blockage. And this can lead to gland atrophy over time, and you can see that here by meibography, infrared meibography, where we look clinically at the glands. The white are the glands against a background that's darker where the glands have dropped out, where we're not seeing glands visible, and we presume is atrophied tissue. So what's the impact of that on the tear film? Well, that has quite a significant impact, because if we don't have the oils the meibum being expressed, then we don't have a good lipid layer. And with gaps in that lipid layer, the underlying aqueous can evaporate more quickly. And we've got evidence to show that clinically, where there's no visible lipid layer or an incomplete lipid layer, then the tear film evaporation rate increases fourfold. So it's very common. Dry eye disease is very common, but lid disease within that is also very common. And a local study we did showed that when we asked optometrists and ophthalmologists about their patients attending their clinics, not specifically for dry eye, just generally attending clinics, and asked how many they would estimate having anterior blepharitis or posterior blepharitis, we found that compared to aqueous deficient dry eye, which was thought to occur in about 5 to 10% of patients, anterior blepharitis was visible in around 10 to 15% of patients. 10 to 15% of their patients. And MGD, they thought, was apparent in between 28 and 35% of their patients attending routine appointments for any eye condition. So extremely common. That's about 1 in 3 patients will show signs of meibomian gland dysfunction. It has a number of risk factors, and I'm not going to talk too much about this because this will be covered in the other presentations. But increasing age is certainly a risk factor. As we get older, we're more at risk of meibomian gland dysfunction developing. There are ethnic differences, with the Asian eye being more predisposed to meibomian gland dysfunction. And you see over here, age combined with ethnicity shows that we see the increased risk in the older Asian eye of dry eye. And there are local environmental factors, the intrinsic ones, including a high bacterial load or Demodex, as mentioned, or extrinsic factors such as air conditioning or device use. And I mentioned device use because of the impact that has on our blinking. When we use devices, we don't blink properly, we don't close our eyelids properly. And there's the chance then that we believe that there's not the stimulus to produce the oils or to release the oils as we should. So all of those impact meibomian gland dysfunction, we believe, and its development. This is a study we did looking at ethnicity. We have the good fortune in New Zealand of having a very highly mixed ethnic population, and we have a high Asian population with second generation Asian individuals. And so we were able to conduct a study comparing people who had lived in New Zealand throughout their lives to try and eliminate at least the differences perhaps in temperature or humidity from other countries, to try and can make things as consistent as possible. And we compared them, and we found that the Asian eye with or without an eyelid crease, so a single or a double eyelid, versus the double lid of a Caucasian eye, we found that the Asian eye was predisposed to meibomian gland dysfunction even in the same environment. And the Caucasian eye, on the other hand, was more highly disposed to anterior blepharitis and telangiectasia. And this has a massive impact on patients, both on a daily basis in terms of their symptoms, how they feel. They complain of red-rimmed eyes, heavy swollen lids, photophobia, tearing, which is a protective mechanism in response to the drying of the tear film, discomfort, transiently blurred vision as the tear film destabilizes, and itching lid margins, where you need to think Demodex. And that has an impact on the quality of life. As it develops into dry eye, then it has an impact on productivity. Patients not only miss work, but turn up at work and can't function properly. There's an association with depression and a financial burden. So it does cause a big burden for our patients and leads to unhappy patients. So what can we do as clinicians to try to do something about this? Well, the evidence shows us that tear film stability can be increased if we express the meibomian glands, if we increase the amount of oil. And if we can improve the stability, that's one way of breaking that vicious circle of dry eye disease. So let's work out how we can do that. So what I would encourage you to do is to take a staged approach to managing blepharitis. It's all very well saying, oh, you just need to warm your eyelids and you'll be fine. But there are a few steps we need to go through first. And so I'm going to talk through it, hopefully in what you'll consider a logical fashion, and in the way that we could approach a patient with blepharitis. So first of all, dealing with the lid margin, then encouraging the meibum outflow, because you can't get the meibum to flow out if the lid margin is not optimized, and then improving the meibum quality. So let's start with optimizing the lid margin. That would be step one. So first of all, we want to free up the gland orifices. And I mentioned the keratinization, which can develop on the surface of the lid margin. And sometimes that can block the orifices. And so it may be indicated to remove some of that keratin from the surface. If you see excess keratin on the surface, this can be removed. We need to also deal with any excess bacterial load. Some bacteria obviously is normal around the eyelid, but if you think that there's overcolonization, we need to deal with that. And also manage Demodex if that's considered to be causing some of the symptoms. So removing the keratin is a technique called lid margin debridement, and that's using a golf club spud. We use topical anesthesia to break down the bonds between the cells. It doesn't do much to help with the sensations, obviously, around the lid, but it does soften the tissue. Lissamine green helps to stain the keratin, and you can then debride gently with a golf club spud to remove that surface layer. And that's been shown to increase the number of functional glands following treatment. Here's an example. If we look top left, you can see the kind of lumpy lid margin here. That's with the excess keratin sitting on the surface. Here it is stained with lissamine green. This is the patient following debridement on the same day following debridement. And here they are 3 months later after debridement. And I mean, not only do you see the improvement in the lid margin, but you see a whitening of the eye. So there's reduced hyperemia, reduced inflammation simply from managing the lid margins and allowing the meibum to flow more freely. We can also clean up the lid margins using microblepharoexfoliation, which is a very long term to basically say cleaning up the lid margins. And I liken this often to dentistry, where you would have your scale and polish. So you're expected to clean your teeth yourself and manage the hygiene at home in between. But every so often you get a scale and polish, which is the deep clean for your teeth, to give it a really good head start to allow the patient to then manage the treatments at home. And so this is what we can do with the lid margins as well, and give the lid margin a really good deep clean the lashes, getting rid of all these crusts to help reduce the bacterial load. And there's evidence showing that it does that, and it improves tear film quality, and can even reduce contact lens discomfort for those affected by dryness with contact lenses. It doesn't remove keratinization, so I wouldn't try to use it for that. It's not strong enough for that. It's a spinning foam tipped applicator, which you wet and then move along the lid margin, as you saw in the video. Patient education, I've put that slide in just because it's so important, so don't forget to do that as well. Obviously it's I'm not sure it's a management technique, but it's incredibly important to explain to the patient so that they will engage and help manage this condition with you, because it's not going to be managed in office alone. It's a chronic condition that requires long-term management. And within that management, I would encourage you to try to avoid baby shampoo. So the next step is cleaning up the lid margins at home. So we may have done the deep clean with something like the BlephX in practice, but the patient then needs to manage this at home. And we can use different types of cleansers, but preferably not shampoo. Baby shampoo is the no tears formula, which is great for babies if you accidentally get it in the eye, but it wasn't a product designed for eye use. And it's a little bit too harsh. And our studies have shown that if you, so we did a double mask study so that the patients using it, the participants using it, didn't know which product they were getting in which eye. And we compared a number of different parameters, as you see on the right-hand side. And if you look at the features that improved with the lid cleanser, they're going to be in green, where the features that got worse with the baby shampoo are in orange. So with the baby shampoo, we saw worsening of the lid margin signs and decreased goblet cell function based on MUC5AC, which we assessed by qPCR from impression cytology samples. However, with the lid cleanser, with a commercial lid cleanser designed for eye use, we saw by the end of a month's treatment, improved gland expressibility, improved lipid layer grade, and reduced ocular surface inflammation through markers of MMP9 and IL-6. So definitely some subtle effects happening where using baby shampoo can actually make the eyes worse. So look out for that, and try to use more commercially prepared lid cleansers that are designed for dry eye or for eye use. And there's a huge range of them out there, and there's not a great deal of good evidence comparing those head to head in high quality scientific trials. Most of them will be effective at removing crusting. Most of them contain surfactants. Some contain tea tree oil for Demodex, which I'll come to in a little bit. And some of them are non-surfactant based, some non-detergent based cleansers, such as those containing hypochlorous acid, which also have the ability to disrupt the biofilm and reduce the bacterial colonization on the lid margin. In some patients, you may find a need to take it a step further if you don't feel that lid cleansing at home is going to be sufficient, and you may prescribe antibiotics. Topical antibiotics, you're going to want to use something such as fusidic acid, which is most effective against gram-positive bacteria, because that's what you tend to find around the lid margins. But increasingly, we're seeing alternative therapies out there. And as a New Zealander, I am New Zealander, I am Scottish, if you're wondering about the accent. But as a New Zealander, I am duty bound to inform you that Manuka honey can cure everything, almost. It was brought to me and I was highly skeptical, but then I had to think about it. And Manuka honey has antibacterial and anti-inflammatory properties, much lower level than antibiotics or steroids, for example. But then blepharitis isn't an infection. It's an overcolonization of bacteria. It's not an inflammatory driven condition. It's low-grade inflammation induced by the breakdown of the tear film. And so I started to become a bit more interested, and there's certainly evidence out there showing that it works for wound healing and skin ulcers and eczema, but there's also evidence out there showing that it has benefits in dry eye and meibomian gland dysfunction. And so at the University of Auckland, we actually developed our own formulation, which we a microemulsion, which became a really nice cream, which could be applied to the lid margins. So it's purely for treating patients with blepharitis. We don't put our cream directly into the eye because it's complex and it would sting, although the other honey products do sting too. And this has been trialed in a 3-month study and found to show improvements in symptoms, improvements in clinical signs, including an improved breakup time of 2.5 seconds on average, which was clinically significant, as well as improved lipid layer and reduced lid wiper epitheliopathy. Demodex count also reduced, which was interesting, and that was consistent with our previous in vitro findings, where the product was compared well with 50% tea tree oil, which is the kind of standard in-office treatment that's used for Demodex, but is very kind of toxic to the surface of the eye. So yeah, it seems to be quite effective. It's not commercially available yet. The management of Demodex currently is usually based around tea tree oil, and that's from an Australian tree, the leaves of an Australian tree. It's antimicrobial, anti-inflammatory and antifungal as well, toxic to Demodex mites, but also you need to be a bit careful because it's toxic to the ocular surface. So you don't want to be getting much of that if you're applying a 50% solution. You're not wanting to get that too close to the ocular surface, and you might want to consider a bandage contact lens to protect the eye while you're applying this, if you do that in practice. Because what we tend to do is, for patients with a marked Demodex infestation, where you believe that to be causing their symptoms, because not every patient will need treatment, and a lot of patients will have Demodex. So it's only those with the kind of intractable, kind of blepharitis that can't be managed with normal treatments, then often it will be Demodex that will be causing the problem. And we may use a course of in-office tea tree oil treatments, a 50% solution of tea tree oil and 50% a bland oil, like almond oil or something like that. And it's done weekly for a few weeks because of the life cycle of the Demodex. You want to make sure you catch the Demodex at all stages of its life cycle in order to help reduce the amount. And if you're going to do that, you want to supplement that with daily hygiene for the patient through wipes or cleansers with tea tree oil in them. There are ones with low levels of tea tree oil in them that can be used at home. And you also want to recommend to the patient that they use facial cleansers and hair and shampoos and things like that as well, because for them because they need to make sure the Demodex is eradicated from, or cut down, reduced in all those areas. So the next step is to, once you've got the lid margin sorted out, is to encourage the meibum outflow. And that's trying to warm the glands, because we know that the melting point of the oil changes. So we need to get the oil to come out, and it usually involves heat, although it may involve intense pulse light, maybe one way of doing it. And often it will include gland expression. So there are different worm compresses out available. This is one that's heated in the microwave. These ones work well, and there's not a huge difference between them from the evidence. We did a study comparing that to one of the portable ones. It doesn't require a microwave. It's got an exothermic reaction, a chemical reaction when you squeeze the two parts of the little foil packets together. And in comparing them, we saw that both of them were effective in improving lipid and stability. But we did find that the wheat bag was able to heat the eyelid to a warmer temperature than the mask, and patients did prefer the feeling of that on their eyes. And compliance is important, obviously, in treating patients. So we figured that really good if you're traveling to have the other one when you don't have your microwave with you, but otherwise probably some of the wheat bags might work more effectively, especially in more advanced MGD where the meibum melting point is likely to be higher. This is a nice study by Etienne Bouton from Canada, which shows that there's not a lot of difference between the different commercial bags that you can use, whether they're wheat bags or glass bead bags. They all retain heat pretty well, but not to use face cloths or washcloths because these do not retain the heat adequately. You want to have a temperature of at least 40 degrees for about 10 minutes, and that cannot be achieved with a face cloth. Heat can also be delivered by latent heat through the blephasteam, which is shown to be effective at increasing lipid and improving stability in normal and patients with normal eyes and in patients with MGD. This doesn't involve the pressure on the eye, so some patients prefer that, and apparently especially kids who are using them because they can still use their computer while they're wearing it. Take that as you like. Top of the range probably would be something like the LipiFlow, which heats the eyelids from the inside. So it's a thermal pulsation device which warms the eyelids, warms the meibomian glands from the inside of the eyelid while protecting the globe, and then compresses the lid in order to effectively milk the glands. And this is a one-off treatment, a 12-minute treatment, which is performed in both eyes. And can give relief for several months after treatment. And this is similar, we see now the iLux, which is available, and I'm not mentioning that here. I know it's available in the States and is becoming more globally available. And it's another device, only it's handheld, which also heats the eyelids from the inside. The evidence for the LipiFlow shows good results even up to 9 months in improving symptoms, gland function and stability of the tears. And that starts to drop off a little bit by 12 months, although there is some evidence to say that even up to 3 years, some of the participants who were treated at the beginning were still claiming benefit from it after that length of time. Intense pulse light has also become popular. It was observed first because of its effect on the skin in acne rosacea and reducing the redness, but coincidentally improved the eyelids in ocular rosacea, in accompanying ocular rosacea, and that was Rolando Toyos who identified that and has made that more popular. And I was fortunate to have one of the first devices in the Asia Pacific and conducted a randomized controlled trial, which was published in 2015. It was a paired eye trial, and it showed improvements in stability, lipid layer, and symptoms, and gave me the confidence to continue using it, because at that point I was incredibly skeptical as well, and allowed us to carry on and do a much bigger and better trial after that. The evidence is showing that overall results are positive. We see improvements in the tear film, improvements in symptoms, decreased inflammatory markers, and improved tear film composition. But when we look at the studies themselves and the scientific quality of the studies, we find that a lot of them are non-randomized, without a control group, open label. They combine IPL with other treatments such as meibomian gland expression, so it's difficult to differentiate the effect from the IPL itself. And basically, when you look at all of that and pull it all together, as Laura Downey and her group did in Australia, you find that there's a lack of high quality scientific evidence supporting its use, and they recommended a need for many more trials showing that were high quality level 1 trials. And I'm glad to say that we have recently published a level 1 RCT looking at the cumulative benefits of IPL. This was with the EI, which is IRPL, intense regulated pulse light. And it showed improvements in symptoms, lipid, reduced meibomian gland capping, and we even saw changes in the bacterial profile, which may also be beneficial. It was a 4-treatment course performed on days 1, 15, 45, and 75, followed up to day 105 with measurements taken a month after the treatment having been applied. So this is not just heat, it's something else that's happening and building up over time, but the mechanism itself still requires further research to determine exactly what the mechanism of action is there. Therapeutic expression is most often combined with any of those treatments. It's a fundamental part of treating meibomian gland dysfunction. Not for our trial where we wanted to prove the benefit of IPL on its own, but in clinical treatments, I would do both. I would do the IPL and accompany that with expression to help remove the oils from the glands. That's performed using something like a Mastrota paddle, something that's rigid behind the lid margin. And you can either use your thumb or you can use a cotton bud or something like that to compress the lid. And you can see with that case some clearish oil coming out. And here we see something that's more like the thickened toothpaste expression of a more advanced case of meibomian gland dysfunction. And you want to try and remove that. When you're doing that as a treatment for patients, try to do it very reasonably gently all the way along and work your way back. If you do it 2 or 3 times, you'll actually get a much better response than just going in really hard in the first pass. And finally, just to finish off, improving meibum quality. Sometimes you get the oil to come out and you wonder if you're regretting that because suddenly the quality of the meibum that's expressed really isn't that great. So you may need to work further on the meibum once you've got that out, and that's step 3. And that can be done using systemic anti-inflammatory therapy, essential fatty acids, or with artificial supplementation. For systemic anti-inflammatory therapy, we have the tetracyclines. We'll often use doxycycline in low dose over a long period of time, though it does have some side effects. And for those of us with the high UV light due to our poor ozone layer, we have to be very careful that patients don't get burnt when they're on doxycycline, because it makes you susceptible to being sunburnt. Also contraindicated in children and in pregnancy. So more commonly, we're using azithromycin, and that's available topically in some parts of the world, but not for us, unfortunately. But we do have systemic azithromycin available to us, so we use that, and there's an increasing literature that shows that that's as effective and certainly at least as effective as doxycycline in treating meibomian gland dysfunction. It's also quite good for compliance because it's taken very quickly at the beginning, not quite a 1 gram stat dose, but close on it, 500 milligrams one day, and then 2 or 3 doses of 250 milligrams a day, and it has less unwanted side effects. Another way we can do it is through the diet. So that can be through essential fatty acids, which we need to consume because our body can't produce them. And often we're reminded that we need to redress the balance between omega-3 and omega-6 because our diet in the Western world favors omega-6 too much, and we need to try and have more omega-3. And that's because the enzymes in our body will compete between omega-3 and omega-6. The more omega-3 you take in your diet, the more that will draw those enzymes towards the omega-3 side into producing anti-inflammatory byproducts rather than the pro-inflammatory products you get from omega-6 breakdown. And if there's enough omega-3 in your diet, it will actually block the conversion to arachidonic acid and that entry into the inflammatory cascade. The evidence in the literature is a little bit mixed. You may have heard about the DREAM study, which threw people into confusion. Early studies showed benefits from omega-3. The recent studies, as I say, questioned that where there wasn't a significant improvement beyond placebo. So not that there wasn't an improvement, there was an improvement with the omega-3, but it wasn't significantly different from placebo. But if you look on balance, and again, Downey's group has conducted a Cochrane review that has shown the evidence overall does suggest a possible role for omega-3 in dry eye, but the evidence, the quality of the evidence is such that it's inconsistent and uncertain. So again, we need more trials to prove the definitive benefit. And we can use topical supplementation if need be as a final means of managing the quality of the lipid layer, and that may be through liposomal sprays, lipid containing drops, and that might be Balance we've got here, but there's a new one, Complete, and we've got evidence to show that that also is effective and also has prophylactic benefits if applied before application, exposure to an adverse environment, which could be useful. So just to wrap up, improving dry eye management requires us to understand the pathophysiology. It's important we try to treat the problem that the eye has. So if it's a problem with the lid margins, then we need to do something about the lid margins, not simply use artificial tears or rush in with an anti-inflammatory. We need to be using sensitive, validated diagnostic tests to pick up dry eye, and then to target those identified deficiencies with the various different therapeutic strategies we have, because that's ever expanding, and there are some new and exciting products that are in trial at the moment that are on the horizon that I haven't talked about today, but look out for those, which might actually even treat meibomian gland dysfunction through managing the hyperkeratinization. And our treatments nowadays are aiming to provide more than palliative care. We're trying to treat the dry eye itself. So our MGD management requires a combination of treatments. We need to be looking at improving the access to the gland orifices. Once they're free and decreased in bacteria, we need to encourage the outflow of meibum from the glands. And then once that meibum has come out, if the quality is not ideal, we need to do something about improving the quality that way as well. And we need to adopt a multifaceted and staged approach. So don't just go with one treatment. We can go with a multitude of treatments if we identify different areas that are inadequate within the tear film. Then we need to look at different approaches that may improve those in themselves. And we can and we'll hopefully embrace those new developments for patient care, but make sure that they're evidence-based. Do look at the evidence as well and make sure you're giving good evidence-based advice to your patients. Thank you very much for your attention.
That was fantastic. And I love how it started because, you know, people who aren't familiar with the dry eye field immediately think we're going to talk about the tears. And what you've started us off with beautifully is the local environment really matters and we can't just ignore it. And I thought that was beautiful how you made it a complex topic a little easier to understand.
Oh, thank you.
Really, really nice. So I don't see any questions in the QA right now, but feel free to add them in or I guess ask you later. I think this is a great time to move on to the next kind of topic of dry eye, which is where we really started as a field. The first connections were with dry eye from the inside, systemic autoimmune diseases that were driving dry eye. And now we understand so much more. Sometimes we forget where we started. So Dr. Pflugfelder from Baylor, who really started again in the beginning of dry eye, describing the links between what's happening on the inside and what shows up on the eyes, is going to give us a really nice review on dry eye from the inside. So thank you so much for being here today.
Thanks so much, Anat. I'd like to thank the organizers for the invitation to participate with my esteemed colleagues in this international webinar. And it's really great to see we can continue to disseminate knowledge even despite the global pandemic. And I'd like to commend Dr. Craig for a phenomenal talk. That's one of the best talks I've ever heard on the local environment, and particularly the role of meibomian glands. As Dr. Galor mentioned, I'm going to shift gears and talk about dry eye from the inside. And we now recognize that dry eye can be a manifestation of systemic autoimmunity, particularly with Sjogren's syndrome that I'm going to focus a lot of the talk on, and that it's a disease that probably a lot of you are familiar with or have heard about. These are my financial disclosures, none of which will be relevant to the presentation. My talk will highlight that systemic diseases can impact the immune cycle of dry eye, that Sjogren's syndrome is a prototypical autoimmune condition that causes keratoconjunctivitis sicca, and that internal factors, including gene polymorphisms, altered immunoregulation, and dysbiosis, contribute to dry eye, inducing inflammation and Sjogren's syndrome. As we heard from Dr. Craig, dry eye is a multifactorial self-amplifying disease, and the ocular surface is subjected to numerous extrinsic and intrinsic factors that can stimulate innate and adaptive immune pathways, leading to epithelial disease and secretory dysfunction that has been referred to, at least in the case of Sjogren's syndrome, as lacrimal keratoconjunctivitis. And this is a dry eye immune cycle that can be impacted by extrinsic factors or trauma, including dry, drafty environments, prolonged video display viewing, post-blepharoplasty or plastic surgery, exposure, contact lens wear, preservatives such as benzoclonium chloride that are in eye drops, and sensory denervation that can occur with zoster or LASIK surgery. Or intrinsic factors that I'm going to concentrate on, like aging, female sex, genetics, and dysbiosis. No matter how these risk factors impact the cycle, they ultimately lead to tear film instability with desiccation of the surface of the eye and tear hyperosmolarity. And it's now known that osmolarity is a very potent immune stress that can activate signaling pathways in the epithelium and resident immune cells, leading to production of proteases and cytokines and chemokines. And if that goes on long enough, it can recruit an adaptive immune response due to antigen presenting cell maturation, generation of autoreactive CD4 T cells, loss of immune tolerance. And that can manifest on the ocular surface as lacrimal gland inflammation, conjunctival goblet cell loss or dysfunction, and corneal barrier disruption with nerve sensitization. Well, Sjogren's syndrome is a prevalent multi-system autoimmune disease. In fact, it's often considered to be the second most prevalent autoimmune disease to rheumatoid arthritis. There's a female predominance of about 95% of patients are women, and there are numerous genetic risk factors have been identified, with the end result of inflammation in the exocrine glands that causes lacrimal and salivary hypofunction and loss of reflex tearing. This is a micrograph or photomicrograph on the left of a lacrimal gland infiltrated with lymphocytes, which usually occur in foci, and on the right, a schematic showing these foci of primarily CD4 T cells and B cells that ultimately can replace the glandular acini. And a lot of, as I mentioned, a number of different risk factors have been identified, including autoantibodies, where circulating anti-muscarinic 3 receptor antibodies, as I'll show you, that's against the muscarinic receptor in the lacrimal gland, have been found in 90% of primary Sjogren's syndrome patients. There are genetic risk factors, including certain HLA-DQ alleles that are associated with increased prevalence of the autoantibody specific for Sjogren's syndrome, SSA and SSB. and polymorphism in the STAT4 signaling pathway that increases the risk by 1.9 and is one of the most reproducible susceptibility genes. And then altered inflammatory and anti-inflammatory gene expression has been identified both in circulating mononuclear cells in the blood and in the target tissues like the lacrimal and salivary glands. And these include decreased immunoregulatory transcription factors such as PPAR and RXR alpha. And in the salivary gland biopsies, high interferon gamma activity, both types 1 and 2, have been found that correlate with decreased function and increased lymphocytic infiltration. And interferon gamma signature has been associated with greater salivary gland focus scores. The M3 receptor autoantibodies can bind to the receptors on the lacrimal and salivary gland acini and functionally paralyze secretion by these cells, because a lot of the lacrimal gland secretion is cholinergic mediated. As I mentioned, altered tear composition, primarily osmolarity, can stimulate production of innate inflammatory mediators. And it's now recognized that osmolarity can reach very high levels, almost as high as 900 milliosmoles in focal areas of tear breakup in the precorneal tear film. And this is actually a more potent inflammatory stress than even microbial products like lipopolysaccharide. And that activates signaling pathways in the epithelial and immune cells, particularly the JNK and NF-kappa B stress signaling pathways, leading to transcription of stress genes, including cytokines, chemokines that recruit monocytes and other inflammatory cells to the ocular surface and causes them to mature, can sensitize nerves and cause pain, and then proteases, particularly MMP9, that can disrupt corneal barrier function. And these increased innate mediators have been identified in the tears of Sjogren's syndrome patients, including cytokines like TNF alpha and TGF beta, and chemokines like IL-8, MIP1 alpha, and Th1 chemokines like MIG, IP10, and ITAC. And MMP9, both the protein level and the activity, has been reported to increase in the tear film. And in one of the studies that we performed, you can see that as the activity increased, activity increased with the categorical severity of the dry eye, with the highest levels in eyes like Sjogren's syndrome. We now know that MMP9 can cause accelerated loss of the apical epithelial cells in the cornea by breaking down tight junction proteins such as occludin, causing accelerated desquamation of those cells. They're the ones that contain the glycocalyx that anchors the tear film, leading to tear destabilization and to exposure of the nociceptors in the wing cell layer of the cornea. And we detect that clinically using diagnostic dyes like fluorescein that then stain areas where the cells are damaged or where there's altered paracellular permeability. Clinically, we can see that as an irregular corneal surface that causes poor quality vision, light sensitivity. Many patients are extremely light sensitive. They blink frequently and may develop corneal ulcers. And these eyes are primed to develop, even rapidly progress to a perforation. And as you can see on the bottom here, that this is a reflection off the corneal surface that shows a highly irregular cornea that has a poor quality vision. The inflammation and high osmolarity can also cause sensitization of the nerves or nociceptors in the cornea, increasing activity and firing of polymodal and cold receptors that can be interpreted as dryness or unpleasant pain, or even just frank pain that we'll probably hear about from Dr. Galor. And mice that have a deletion of the JNK2 signaling pathway that I mentioned is activated by osmotic stress are resistant to desiccation induced dryness. As you can see here, exposure of B6 mice to 15 and 30 days of low humidity, drafty environment causes alteration in their corneal barrier function. But you can see in the bottom panel that the mice that have a genetic deletion of J and K2 were resistant to that. And that also correlated with no increase in these innate signaling pathways or molecules, including MMP3 and MMP9. Other studies have actually shown that genetic mutations that increase activity of NF-kappa B can also result in Sjogren's syndrome-like lacrimal keratoconjunctivitis. And using two different models to inactivate one of the suppressors of NF-kappa B, mice developed inflammation in one model in the lacrimal and salivary glands, as well as the liver, and in another model in the periocular skin and the conjunctiva, again showing the importance of these signaling pathways, and increased activity can lead to inflammation. The tear fluid that's produced by the lacrimal gland is replete in both growth factors and immunomodulatory factors. There's very high levels of epidermal growth factor, nerve growth factor, and TGF-beta, and then high levels of vitamin A in the form of retinol and lactoferrin. And some of those factors actually will maintain the health of the ocular surface epithelium, but they also can maintain the antigen-presenting cells on the ocular surface, particularly those in the conjunctiva, in a more quiescent, immature state where they're not effective in phagocytosing autoantigens, and they don't produce cytokines that can cause them to migrate into the regional lymph nodes and polarize autoreactive T cells. And in fact, the dry eye relevant danger signals, including osmolarity and cytokines like IL-1 beta, can promote antigen presenting cell maturation and production of these T cell priming cytokines. In particular, osmolarity increases production of Th1 inducing IL-12 by mature antigen presenting cells, both dendritic cells and macrophages on the ocular surface, leading to interferon gamma production both by those innate cells and by Th1 cells that they prime. And some of the lacrimal gland factors like retinoic acid actually can suppress the maturation of these cells and production of IL-12. In a recent study, we found that there were more mature antigen presenting cells in the conjunctiva of patients with Sjogren's syndrome, keratoconjunctivitis sicca. There were higher numbers of MHC2 or HLA-DR or immune cells, and that was found in both the superior bulbar and the entire ocular surface. And the greater the number of the HLA-DR positive cells on the ocular surface, the lower the conjunctival goblet cell density. As I mentioned, if this desiccating stress goes on for a while, it can lead to antigen presenting cell maturation, and those cells can then jump into the lymphatics and traffic to the regional lymph nodes where they prime autoreactive T cells that then home back to the ocular surface and produce cytokines like interferon gamma that can cause goblet cell loss, as well as IL-17 that can cause corneal barrier disruption. And it's now known that interferon gamma is even minute quantities can cause secretory dysfunction and apoptosis of the conjunctival goblet cells, and that mice that are deficient in interferon gamma are resistant to desiccation-induced conjunctival goblet cell loss. Goblet cell loss is a prominent feature in both Sjogren's syndrome and non-Sjogren's syndrome aqueous tear deficiency, but not in meibomian gland disease, as Dr. Craig had talked about. We have found that in both non-Sjogren and Sjogren's syndrome aqueous deficient patients, there's increased expression of this Th1 cytokine interferon gamma, and the higher the expression, the greater the lissamine green staining and conjunctival goblet cell loss. And we often use lissamine green staining, particularly this kind of pattern shown here in the exposure zone, as a surrogate marker for this type of inflammation in the conjunctiva. If we add interferon gamma to our mouse model of dry eye, it accelerates conjunctival goblet cell loss. As you can see here, there's about a 30% decrease in goblet cells from the desiccation, and a further significant decrease when interferon gamma is added. And you can see that in these micrographs on the right showing with interferon gamma compared to without in the center, where there's a marked worsening of the conjunctival goblet cells and also changes in their morphology. And the number of CD4 T cells that are found in the conjunctiva in this mouse model corresponds to the amount of goblet cell loss, again, tying in the immune aspect. And interferon gamma knockout mice are resistant to the this desiccation-induced goblet cell loss. We also know that if we neutralize interferon gamma in these mouse models, we can improve disease by decreasing CD4 T cell infiltration, increasing cytokines like IL-13 that stimulate goblet cell production, and increasing the number of goblet cells on the ocular surface. And again, you can see here with the anti-interferon gamma treatment, there's regeneration of goblet cells in the mouse conjunctiva. And T cell inhibition has also been found to occur in human eyes with Sjogren's syndrome that are treated with a topical cyclosporin A, which is the first FDA-approved dry eye therapy in the United States and worldwide. As you can see on the left, in a patient with Sjogren's syndrome, before cyclosporin A therapy, there were very few goblet cells, many that barely stained with a PAS dye. And after 3 months of cyclosporin A therapy, regeneration of many goblet cells that now appear normal in size in their staining. And this biological activity is actually the one marker that has been consistently found in clinical trials of topical cyclosporin A. I'd like to conclude with another risk factor that's been identified in Sjogren's syndrome, both by our group, by Dr. Galor's group, and also by a number of groups worldwide, and that's dysbiosis of the intestinal microbiota. Commensal gut bacteria are known to ferment starches and produce anti-inflammatory short-chain fatty acids such as butyrate that then circulate through the body and have immunomodulatory effects. And gram-negative pathogenic bacteria such as E. coli can release pro-inflammatory molecules such as LPS that can circulate and also stimulate innate inflammatory pathways. In a study that we published about 4 years ago, looking at stools from normal subjects and those with Sjogren's syndrome, we found a decrease in the short-chain fatty acid producing commensal bacteria and an increase in pathogenic bacteria that produce molecules like LPS. And there was also an overall depletion of diversity in the intestinal microbiome. And you can see from this graph that there was a pretty strong correlation between combined clinical severity using the ELAR severity scores for Sjogren's syndrome and the number of OTUs identified in the stool. We have then gone on to look at germ-free mice to see whether removal of commensal bacteria can cause Sjogren's syndrome like disease. And in fact, these mice do develop spontaneous conjunctival and lacrimal gland inflammation. They develop corneal fluorescein staining similar to human Sjogren's syndrome. They lose their conjunctival goblet cells and develop lymphocytic foci in the lacrimal gland similar to Sjogren's syndrome. And these foci are composed of both CD4, CD8, and B cells, and EGF production by the lacrimal gland decreases. Restoring or attempting to restore the commensal bacteria in the gut with fecal gavage from normal mice did improve the severity of the clinical disease. And you can see here, these are heat maps or showing the various bacteria. This is in a normal B6 mouse, and these are the mice the germ-free mice reconstituted with fecal gavage from normal mice. And although it's not identical, there certainly are bacteria there, including some short-chain fatty acid producers. And when we looked at the goblet cells in these mice, there was a significant increase in the number of goblet cells, as well as improvement in other inflammatory and immune markers, and a decrease in IL-12 production, the cytokine that I mentioned at the beginning, that was involved in generation of Th1 cells. So in summary, Sjogren's syndrome is a disease where dry eye occurs from the inside. Sjogren's syndrome has internal changes that promote development of severe dry eye with production of autoantibodies that can suppress lacrimal and salivary gland neural stimulation, polymorphisms of genes that are involved in interferon gamma production or suppression of interferon gamma, decreased expression of immunoregulatory transcription factors that suppress NF-kappa B activation and IL-12 production, and intestinal dysbiosis that promotes dry eye, possibly from reduced levels of anti-inflammatory short-chain fatty acids. I'd like to, again, thank you for the opportunity to participate in this symposium with my colleagues, and to thank our funding agencies, including the National Eye Institute, and my many colleagues and members of our Ocular Surface Center here at Baylor College of Medicine. Thank you.
Steve, that was great. And I think what's amazing is we've been studying Sjogren's probably for the longest time as it relates to dry eye, and there's still so much we don't know. Now that we understand more about these mechanisms, what do you think is kind of in the pipeline on learning how to block them? I mean, do you see going after interferon gamma? Do you see after going genetics? Now that we have CRISPR-9, do you see going after, the gut microbiome? How you have all this knowledge, what are we going to do with it?
Yeah, I mean, I like the idea of going after some of those, even to try to bolster our own defense mechanisms or immunomodulatory mechanisms, which are, have gone awry in Sjogren's syndrome, whether that's through gut microbiome or natural molecules like retinoids that can, decrease immune activation. So, I think the future is bright, and there's lots of different ways to attack these things. And, sometimes some work, sometimes they don't. And then we have to be careful also not to disrupt immune pathways that are essential for protecting us from bacteria and viruses. So to do it in a way that's very selective.
More relevant now than ever. So
Exactly.
Definitely want all the viral protection I can have. So what I thought was so beautiful about this is, there's this interplay between the inside and the local environment. And of course, you guys sold it like these are two completely separate pathways, but of course they intermix. So I don't know if either one of you can comment, how does the inside environment affect the meibomian glands? What do you do if you have a meibomian gland problem, but also an inside environment problem? How do you think about those two entities when dealing with an individual patient? Either one of you.
You may have different aspects going on, and I think all of them need to be managed independently. So if there's autoimmune disease going on and there's meibomian gland dysfunction, then you need to be managing them both independently. You need to be acknowledging all the different entry points that you can find onto the vicious circle of dry eye disease, and then trying to fix each one of them as best you can to try and get the patient off that vicious circle. So yes, absolutely, they all need to be managed independently, because you'll find that most Sjogren's patients will have meibomian gland dysfunction as well.
Steve, have you looked in the meibomian glands to see if some of the same things that you're seeing on the ocular surface happening within the meibomian glands?
Our mouse models do develop inflammation around the meibomian glands. We haven't investigated it much, but clearly there's a lot of inflammation there. So that could be one aspect. And as Jennifer mentioned, the changes in lipid and tear stability, that induces inflammation on the eye. So susceptible individuals, say they're pre-Sjogren's syndrome, and they've got this chronic, like if they develop meibomian gland disease and chronic kind of activation of the surface of their eye, who knows, that might tip them off into more severe disease or overtly clinical disease.
Well, just in case you guys didn't think it was confusing enough, it's not just the inside and the local environment that you have to think about, but also the external environment. So I'm hoping to add one more piece of the complexity puzzle to convince everyone that they need to go into dry eye research because there are just so many different aspects to tackle. So I'll start sharing my screen here. So to thank you again for staying with us and for listening to me talk a little bit about, is it me inside local environment or is it my environment? And the reason we're talking about this is because we've heard a little bit about dry eye and Sjogren's, and we know that dry eye can occur in the setting of an autoimmune disease, also graft versus host disease, which we didn't talk about, but we don't often hear about dry eye and the environment. And the question is should we? And so what I want to cover today is I want to talk a little bit about the epidemiology of dry eye as it relates to the environment. I want to talk about the personal microenvironment and what that means. And again, bringing it back to the clinicians, I want to ask whether we can modulate the environment as an approach to dry eye treatment. All of this work has been done in conjunction with an amazing environmental epidemiologist, Dr. Naresh Kumar, and it was funded by the National Eye Institute. So number one, is dry eye affected by the environment? And we've had several high-level studies that have answered that question for us. And the answer is yes. So I'm fortunate to work in a clinic where we have hospital-based records that I can access anywhere within the US. So I looked at any patient that was seen in a VA system across the United States. And what I defined as cases, anyone who had a dry eye diagnosis and used dry eye medication. So it's not perfect, but this is what we have when we have big administrative databases. And what we did is we plotted the prevalence of dry eye in each unique zip code. And a big dot is a high prevalence and a small dot is a low prevalence. And you can already see by looking across the map that the prevalence of dry eye is not uniform across the continental United States. So there are other databases that you can look at levels of air pollution, and that's what I'm showing here below. And what's really nice is if you, even before you put statistics to it, you look at the big dots on the upper graph and the big dots on the lower graph, you see that they match up. And if you put statistics to it, you see that if you live in an area that has higher levels of air pollution compared to the mean, you have a higher prevalence of dry eye in that location. And we also could look at other components of the environment like humidity, and areas with higher humidity had a lower risk of dry eye. So we were kind of excited by that. We wanted to see what else could the data tell us, and what we found out that the diagnosis of dry eye has a seasonal pattern. So again, we used the same population, same definition, and we looked to see when were people getting diagnosed with dry eye. And you can see here a spike in the spring, and the spike in Miami where I live is higher than across the United States. But you can, in both areas, you can see more people are getting a diagnosis of dry eye in the spring. So why is that? Well, what we decided to do was make a little graph here where we looked at allergy index, and that's driven by pollen counts and prevalence of dry eye. And you can see that people are getting diagnosed with dry eye in two clusters. There's a winter cluster associated with a low allergy index. So what's happening? We thought maybe it's people spending time indoors, not in Miami, but in other places with heat and low humidity. And then there is a spring cluster where the diagnosis is being linked to high allergy index. And here we think that the quote dry eye diagnosis is really being driven by pollen. And it's not just us. Other groups have looked at dry eye, again, with diagnoses, linking it to high wind, high temperature, and cooking sources. And most of these studies were done in India. But the problem with these administrative databases is that dry eye, hopefully you've seen by now, is an umbrella term, and it contains symptoms and signs. And within the signs, there are various signs: staining, tear stability, tear production. And so the question is, what component of dry eye is being driven by the environment? So we actually have an ongoing dry eye epidemiological study, and we decided to look at that data in a slightly different way and look to see symptoms and signs of dry eye at every month. And what we found is that very similar to our ICD-9 diagnoses, we found that symptoms kind of had a seasonal pattern where patients ended up having higher symptoms during spring and winter. Signs, it was less so of a pattern, although we did see a little bump in corneal staining during the spring. So it turns out that it's more symptoms that are being driven by the environment than signs in our one study. So I think we should back up a little bit. And when I say environment, what do I mean? Well, there's an outdoor environment and there's an indoor environment. And right, we spend different times in different places. We spend time at work, we spend time in our home. And so what are the facets of the environment in these places? So the first thing we wanted to understand was, what about short-term exposures versus long-term exposures to indoor environments? And so we decided to model it on campus. This is the campus of the University of Miami, and we have lots of different buildings to choose from. So we have a library that was built many, many years ago. And we have a newer building that was built with eco-friendly concepts in mind. And we had one of our research fellows stand outside these buildings for a few hours a day and ask lots of questions about age, gender, how many hours a person spent in the building. And what we were really interested was about dry eye symptoms. And the reason we did that is because we hypothesized that the environment inside these buildings was not the same. So again, what do I mean by environment? I mean things like temperature and humidity. I mean things like air pollution. I mean, and air pollution is complex. It includes particulate matter. It includes bioaerosols like mold, bacteria, and pollen. And it includes gaseous pollutants. And the nice thing is we can measure all of this. And so we have another amazing research fellow who would come in with our environmental profiler on the go. And what we're really excited about is this real red box called the Precise, built by one of our engineers, Dr. Kim, that can measure gaseous pollutants on the go. And so not surprisingly, the environment within these two buildings that we chose was not the same. The older building had a higher number of particles, higher relative humidity, and higher airborne bacterial colonies. Interestingly, nitrogen dioxide levels were lower, probably because the newer building is located next to a highway. And so this is just an example of some of the samples we collect. And you can see here dots, more dots, higher counts of airborne bacteria. And then you can see here that the dots are different sizes and different shapes and different colors. So the different colors indicate different bacteria and fungi. So the big question is, the environment is different. What about dry eye symptoms? And what we found that if you exit a building that has an older building with higher particles, higher bacteria, people had higher frequency of dry eye symptoms. But what we found was more interesting is, forget about baseline dry eye symptoms. We looked at worsening of symptoms, and that is where we really saw big differences, where if you came out of the older building, Calder Library, you had a higher frequency of worsening of dry eye symptoms. And the frequency at baseline and was higher in females than males in both buildings. So if you adjusted for these confounders, if you left this older building, you had a 13 times higher risk of having worsening dry eye symptoms. So what we concluded is that short-term exposures to an adverse environment can affect dry eye symptoms. And other people have found this as well, because our work really fits into this bigger concept of sick building syndrome, which consists of lots of different symptoms, of which some of them are eye symptoms. And people have postulated lots of different contributors, of which some are air pollutants and bioaerosols. But what about other environments, right? We spend a lot of time in our home environment, and we wanted to understand, how does it impact our eyes? And so again, we were lucky enough that Frank agreed to take his environmental profiler on the go and go visit homes of individuals who volunteered for our studies. And so this is what we measure. We look at agar to look at microorganisms in the air. We have membranes that can collect particulate matters and pollens. We have an aeroset, which counts particulate matter. We have these cells that trap pollen and mold. And then we have our Precise, which we're very excited about, which quantifies gases in the environment. And so if you volunteer for our study, you get an update with information about what is being given, what are the parameters are in the home, including temperature and humidity, the number of particulate matter, reactive gases, and microbial concentrations. And this is just an example of some of the data we get from the aerosol showing the types of molds and pollens we can see. And more than just what you have, we also give information on how to make the environment better. So if you know anyone in Miami, tell them to contact us. We're looking for volunteers. If you remember nothing else about what I'm describing today, the punchline is that different exposures within your home will have different consequences. And the reason that we think this is because all pollutants have different properties. So for example, we have something called PM, the particulate matters, and they come in different sizes. And so PM10 are things like dust and pollen and mold, and about 4 of them will fit across a hair. But then there's something PM 2.5, right? So these are much smaller particles, and they're the result of combustion products or metals, and those are much, much smaller. So you can already see that those would create maybe some differences on the ocular surface. So for example, PM10, they're kind of large, they're too big to penetrate. So they probably disrupt the tear film, where the PM 2.5, they're very, very small and they can penetrate in. And so there you can start seeing that they may influence the deeper components of the cornea and irritate nerves. And so we actually looked at that. We had a series of almost 100 patients where we measured their dry eye parameters and we went to their home and measured their environment. And what we found is that if you looked at dry eye symptoms, they were more closely related to the smaller particulate matter, the PM 2.5. And again, we're hypothesizing it's because those PM 2.5s are able to go into the cornea and irritate nerves. But both PMs were related to adverse dry eye signs, like low tear production, dropout of meibomian glands, what Dr. Craig talked about, and inflammation on the ocular surface. Now, humidity also is really interesting because there have been really beautiful studies of these adverse environmental chambers. This chamber looks very scary. You go inside and there's very low humidity and they make you watch a movie, and not surprisingly, the dry eye symptoms and signs get worse. But what we found is that if you have high humidity, your dry eye symptoms and signs also get worse. And the reason for that, or at least that's what we think, is because humidity and particles interact. So if you look at the same particle, it will look different, larger, the higher the humidity. And that's because humidity has a negative effect on PM size. Higher humidity, higher PM size. And we think it's that interaction between humidity and particulate matter, not the humidity itself, that's driving our findings. So with humidity, there's something called a Goldilocks zone where you want it to be just right, not too high, not too low. And again, living in Miami, that's really, really challenging. Okay, so what about microbial concentration? So we looked at about 165 individuals, and what we found is that microbial concentration was associated with corneal staining and also with meibomian gland dropouts. So again, it's not just what's happening on the surface, it's how these bacteria are interacting with the local environment. And actually, Dr. Craig, maybe you have some ideas. I'm not sure whether the bacteria are getting in there and actually part of blocking and keratinization, or whether they're changing enzymes that then affect the function. But we think it's not just the ocular surface, but also the eyelids that are being affected by our environment. Now, we also have this very cool precise machine, and we have not finished looking at the data. So this is just a prelim assessment of our first 59 patients. But what we found is that carbon monoxide was most associated with inflammation on the ocular surface. But this is preliminary, and I'm not sure if it's going to hold when we look at the larger set. But kind of summarizing our findings in the literature are that different types of pollutants have different effects on the ocular surface. So, but the particulate matters, 10 and 2.5, associated with tear film abnormalities, inflammation, bacteria, corneal staining, meibomian gland dropout, carbon monoxide, inflammation, and ozone more associated with symptoms in the literature. So hopefully, if you guys have been paying attention, I've been talking about looking at what's in the environment and linking it to the eyes. The question is, though, does the air pollution actually end up on the eyes? And the answer is yes. So we had a really fantastic master's student who took Schirmer strips and ran them through scanning electron microscopy. And what she found was that she could detect particles on the Schirmer strips, and she could categorize them as organic or inorganic. And within inorganic, she could then look and see what the different particles were. Now, do these findings correlate with dry eye metrics? So we need more data because we only had 15 patients in this study. But what we did find is the area of the particles related to inflammation on the ocular surface. But again, this is a really exciting area and we just need more information. Now, we've been talking a lot about dry eye, but actually that's part of a larger picture of ocular surface diseases. And another ocular surface disease is allergic conjunctivitis, which has often been felt to be separate from dry eye. But the question is it really that separate? Is there an overlap between allergy and dry eye? And what we think is probably, and the reason is because we did a great study with Harrison Dermer, who's now an anesthesia resident in the lab of Abigail Hackham. And so beyond finding that dry eye has a seasonal pattern, we wanted to look for more evidence. So what we did is we took Schirmer strips, which have tears, from 75 individuals who had a diagnosis of dry eye, but no diagnosis of allergic conjunctivitis. And they were diagnosed both with a combination of symptoms and signs. And then we looked at IgE, which is one of many markers of allergy. And it's not totally specific for allergy. And we lumped patients into three groups. Either they had no detectable IgE on Schirmer's, they had low or high levels. And what we found is if you had high tier levels of IgE, those patients had higher frequency of allergic triggers, like having pets in the home, like smoking, like having their tears taken during springtime, or being born in the US versus outside. And so what we think this shows us is that there's really an overlap, and some people who are diagnosed with dry eye may have allergic contributors. And this has treatment implications. So I've given you a lot of epidemiology information, but the question is, what should we do with all this information? And I think what we're trying to get at is that you need to understand your personal exposures and improve what you can. So one thing is to reduce bioaerosols, and you can put UV light in AC units, or if you identify mold, which is a problem in Miami, consider mold remediation. It's really important to titrate humidity into that Goldilocks zone and keep the temperature at less than 72 degrees Fahrenheit. This is a problem in Miami, and we're really struggling with this. And it's important to change your air filter every 1 to 3 months. It's amazing when we go into patients' houses, some of them don't realize that air filters need to be changed. What else? Important to clean. Bathroom, kitchen faucets. These are areas where lots of bacteria can be found. In patients who are susceptible, eliminate carpets if you can, and consider ventilation, except if you live by a highway, sometimes the outdoor sources of pollution are even worse. So really important to understand both indoor and outdoor sources of pollution. There are different ways to reduce air particles, like with air purifiers. Cleaning of air vents, that's another easy fix that many people don't realize they can do. What about CO2? Well, high levels of CO2 open the door and get out, but we're talking about low levels of noxious gases. And plants have been really great at remediating some of these environments. Of course, like everything, there's a balance. And this is an example of philodendron toxicity. So don't get the plant matter in your eye. Keep it in your home to help remediate your environment. And the thing is we don't have to reinvent the wheel. This has actually worked for other diseases. So asthma is the one that people have studied the most. And people have found that if you have an intervention versus no intervention, symptoms go down, and not just during the study period, but even the following year. So if you can reduce dust and cockroach allergens, asthma complications go down. People have looked at it in other environments where they've split patients into, or families into education versus with remediation, like looking at sources of water infiltration, heating, air conditioning alterations. And again, the same thing, asthma complications go down if you change the environment. And it's not just asthma, it's also the work environment. There have been studies that have looked at mold damaged schools versus non-mold damaged schools. And teachers in schools that have mold damage had a higher frequency of conditions linked to mold, like sinusitis. But if you remediated the school, the symptoms and signs got better. So this is something that's worked for other environments, for other diseases, and high likelihood that this would also work for dry eye. Now, I work in humans. I always love Dr. Pflugfelder's pictures, but he gets to ask really great questions in animals that we just can't ask in humans. So if you take a teardrop and put it on a mouse cornea, that mouse cornea is pretty happy. But if you take a teardrop filled with air pollution and drop it on a mouse cornea, you can see here corneal staining. You can also see decreased tear breakup time, inflammatory cytokines, reactive oxygen species, all these things that we see in humans, we can replicate in mice with air pollution. And we can do this after short-term exposure and long-term exposure. So here, mice and men are not very different. So the punchline is that the environment matters. And it's important looking at a more global picture because things are changing. The end of the last ice age occurred around the time of human civilization. And looking at levels of carbon dioxide, we are really higher than we have ever been in the past. And so there's evidence of this. You know, the temperatures are rising, the oceans are warming, and the ice sheets are shrinking. And the reason I care is because I live in Miami and our elevation map is not that high. And so hopefully I won't be looking for a job anytime soon, but climate change is definitely something we think about in Miami. But more than just for us as a civilization, for us as clinicians, what hopefully I'm pointing out is that climate and weather contribute to dry eye, and they're becoming more extreme. So we need to prepare ourselves to see more dry eye. And it's actually not just dry eye, it's allergy, it's infection, it's cataract. There are different eye diseases that are driven by climate that may change in frequency and presentation because of the changes we're seeing. So what are the take-home points? Dry eye, they're related to the local environment, to what's going on in the inside of your body, but also to environmental exposures. Some exposures are easier to modify than others, but the punchline is to figure out your individual exposures and modulate them. And so with that, I'm done with my part. I'll stop sharing the screen. And I want to thank everyone for being here. Dr. Craig, Dr. Pflugfelder, any other comments about how this all ties in together?
Anat, that's fantastic. Yeah, no question that that pollution and environment impacts the surface of the eye. I think it's, you know, our eyes are exposed all day long to that. You know, even coronavirus can be gain entry through the goblet cells on the surface of the eye. So yeah, it's definitely probably something we need to pay much more attention to.
Yeah, I think it's amazing to see the range of different features that can interact with the eye, the way that the tear film can become out of balance, the way we can lose homeostasis in the tear film, and all the different things that we need to be watching for. And I think what I really liked was the fact you wanted to take an individual approach, because I think we need to be thinking about that for our dry eye patients. They're all different in some way and may need a slightly different management strategy. And I think, you know, improving their environment individually is going to be part of that. And it shows how important it is to get the patient on board with what you're doing, to make sure they're helping to make life better for themselves, as well as whatever we can do within clinics. So it's awesome. Lovely talk. Thank you.
So thank you all for truly looking at dry eye 360, inside, local, and outside. It's an exciting time, kind of a crazy time right now, but dry eye seems to be right in the middle of it. So I hope that we can continue to see great questions, great research to come. So Elena, I turn it back to you to conclude the session.
So yeah, before we go, I'd like to thank once again Anat Galor, Jennifer Craig, and Steven Pflugfelder for their contribution and for your talks. And if you have any questions, you can also write them to the webinars@mdpi.com email address. Also, we're interested on what you thought about the webinar, and we are open to any comments. And also the certificates of attendance will be available on demand to webinars at mdpi.com. So I think we will finish here today. Thank you very much again. Thank you all for joining us, and goodbye and take care, all of you.
Thanks, Elena. Thanks for offering this.
Thank you.
Thank you all.
Bye-bye.